this is Dio, and welcome back to the DIOnavi user manual series. Today we will go over the DIOnavi Master Kit. This is the DIOnavi Master Kit. Let's take a look at the drills one by one. When you receive the protocol, you will have to use the tissue punch first. The tissue punch has a diameter of 3 pi and has the smallest diameter in the implant industry. Since it has the smallest diameter, it has a hemostasis effect after the surgery, and it can heal very fast. And people also prefer small diameter because the scar is also small. The recommended RPM should be proceeded at 100 RPM, and the inner part is composed of a double blade. Think of it as a blade of a blender. And the area to be removed is the same as the picture on the right. Tissue punch is literally a drill that punches a hole and removes soft tissue. Its height is 12 millimeters from the top to the bottom. The double blade needs to be taken care of in this drill. After removing the patient's gum, there might be debris left in between the blade. So after using it, you always have to remove them with a sharp point like an explorer or blowing them with an air steam. Next is the bone flattening drill. There are 2 black markings on the bone flattening drill. From the bottom to the top black markings, you can see that the offset lengths is 9, 10.5, and 12. If the drill has markings, you can say that it goes up by 1.5 centimeters. The drill you saw earlier is a drill that removes tissue. This drill makes the bone flat. Every patient has different bones that are flat, zigzag shaped, or sloped, so they all should be trimmed flat. This will prevent the drill from slipping. Sometimes there is some tissue left after using the tissue punch, so some clinicians use tweezers to rip them out. But do not rip them out in that case. Just use the bone flattening drill and all the soft tissue that is remaining will be removed. Usually 100 RPM is recommended, but if the cortical bone is thick or hard, it can be drilled at a higher speed. If you look at the picture, there is a tooth to remove. If you remove this tooth, there will be remaining bone left, and the bone will be tilted and uneven like this picture. If you drill a 2x5 here, it may slip like this. It will not drill in a straight line. If you use a bone flattening drill first, you can make the bone flat like this, and then the 2x5 will go in straight. The following is the 2x5 guide drill. This drill has a chubby upper part. You can use this drill without the drill tube with 100 RPM when the mouth opening is too small. The drill should be in close contact with the inside of the guide sleeve, but it will slip if you drill without contacting the inner part of the sleeve. You have to fully insert it in the hole and make contact with the inner part of the sleeve and reach the bottom before drilling. The initial drills are the drills with 2 mm diameters, and they consist of drills with lengths from 5 mm to 13 mm. The bottom of the drill to the black line is a value for that specific drill length that is written on the shaft. Considering the pointy triangle at the bottom of the drill is 0.5 mm, the actual drill depth is 5.5 mm in total. And the distance to the stopper above the black line is 9 mm, which is the offset value. The initial drill is the most important drill, as it starts off the whole drilling process and pinpoints the location and direction of the drilling. Basically, you drill the smallest 5 mm drill and then proceed according to the fixture size. So you have to install a tube to prevent movement in the hole. There are 2 types of blue tubes in the kit. There is a regular size and a long size. If you want to order, there is an even longer drill tube available. When placing implants in a tooth extracted hole, you can use a long tube. A typical tube may go astray as the drill enters, but a long tube has a larger and longer inner area that has more contact points with the drill, so the drill is less likely to go astray. The larger the contact area, the more stable the drilling is. Drill tubes can also be selected and used depending on the length of the sleeve offset. When drilling, the drilling must start after the drill touches the bone. Many clinicians who suddenly change to a guided surgery when they've been doing general incision surgery before Usually start drilling by starting the location outside the patient's mouth before placing in the hole. These clinicians need to know that they should start drilling after making sure the drill touches the bottom of the hole first. This is the 2.0 drill tube. In this picture, the gray part is the drill tube. If you look at the gap between the sleeve and the drill, there is a 0.01 mm difference. There is a rate of error in the angle, which gets bigger if the gap is bigger. This compares DIO's guide and the guide from a different company. I'm moving the initial drill that's in the guide. While the drill tube moves a lot in the guide from a different company, the drill tube in the DIOnavi guide doesn't move much. You can see the difference in the movement. I made this data a long time ago, but I guarantee that now there is no more precise error rate than what we have today. We can see that it accurately goes in because we focused on designing everything based on accuracy. This is the final drill. After the 2.0 drills, you can drill with the final drills. The drill body and the guide sleeve fit well together, and the final drill goes in without a drill tube. Then it is drilled to fit the fixture size. The recommended RPM is 100. And double contact is very important. You can't just roughly put the drill in and start drilling. You have to make sure the top side of the drill touches the guide and the bottom side touches the bone before you start drilling. Thus the term double contact. This is a case where the drill didn't contact the sleeve. If you look at the picture on the left here, there's a gap between the sleeve and the drill. If you start drilling without double contact with the bone and sleeve, it will turn sideways like this picture on the right. However, if the contact is perfectly obtained from the top and the bottom, it can go in straight vertically like this picture. This is a profile drill. Profile drills are located at the top of the kit. The purpose of the profile drill is to prevent excessive torque and flatten the bone. It needs to be drilled with a torque value of 50 to 55. If you look at the picture on the left, this is what happens sometimes when you don't use the profile drill. The fixture is tapered type, so it doesn't fully go in. If you use the profile drill here, it will look like a picture on the right. This drill is not used to delete or shape the total hole, but just to open the top. This is an abutment profile. It is shaped like an umbrella and it has blades on both sides. It has a diameter of 5.1 millimeters and there are 3 different heights, which are 9, 10.5, and 12. The role of the abutment profile drill is to remove the bone that interferes with the abutments that come on top of the fixture. The picture on the left shows how it is before use. How the bone interrupts the abutment from going in fully. This drill removes the interfering bone. It is deleted in a U shape like a picture on the left. And it is used to cut the bone so it goes in at a high speed of 1000 RPM. You have to go in a circular motion, not an up and down motion like the other drills. If you twist it, your gums might be damaged, so you must be careful. You have to put it in vertically and rotate it on the spot. This is a bone profile drill. After the fixture is placed, the abutment is seated and the guide is removed. But if the bone interferes with the abutment, remove the cover screws during the second surgery and place this drill on top of the fixture. The end of this drill is made of rubber, and there are blades on top of that. So if you put this on the fixture and rotate it, it will delete the bone near the top of the fixture that interferes with the abutment. If you look at the picture on the left, there is a part where the bone is interfering with the abutment. But if you remove the bone with this profile drill, the abutment will go in fully, like this picture on the right. This is an implant connector. There are 2 types of implant connectors. One has markings without a stopper, and one has stopper without markings. The non-stopper has markings in case the fixture is placed in different offsets of 10.5 or 12 rather than the normal offset of 9. The stopper is there to stop the implant from going in deeper than the normal 9mm offset. When you use the one without the offset, it can go in deeper, so the surgeon has to watch how deep it goes. The implant connector is used to stably place the fixture on the guide sleeve in a specific depth. You can push the implant connector with a stopper all the way in. And for the implant connector without stoppers, you can place it up to the bottom of the black marking for 9mm offset, top of the black marking for 10.5mm offset, and to the edge of the connector for 12mm. Also, if you want to connect a customized abutment or H-scan body, both the depth and the direction of the implant connector and the guide sleeve must be matched. The white line on the connector and the bump on the sleeve must be aligned if you have prosthesis made in advance. If you're going to place a healing abutment, there's no need to align it. But when seating a customized abutment or an H-scan body, you must align the white line on the buccal side. You have to match this marking line and the protruding bump of the guide sleeve like this if you have any pre-made prosthesis. An implant connector has a very close tolerance. It fits very tightly, so if the pass deviates just a little bit, it will be difficult to take it out because the tolerance is too tight. At this point, you can use three options. You can first remove the implant connector with a surgical guide. For the second option, you can use a device called a crown remover. It's for removing crowns. This device is a part that looks like a hook, and you can hook the implant connector on the edge. This device also has a sliding part in the middle. If you tap on the sliding part to the top after hooking the implant connector, it will come out. You can also use a periosteo elevator and hoist it out by using the guide as a lever. I have a tool that looks like a pair of scissors. This is called a pair of Kelly forceps. You can use this as a lever or just pull it out. If this doesn't work, you can just remove the surgical guide. This is a connector extension. You can use the connector extension if your teeth get in the way on both sides. You can choose between a machine type and a ratchet type. This is the drill extension, and it extends the drill. You can connect the drill at the end of the drill extension and start drilling. Sometimes the surrounding teeth get in the way of the handpiece, so it may be drilled slightly slanted. To prevent this, you can use this extension to extend the drill. Next is the torque wrench. The torque wrench value is turned with this part in the red square when the bone is hard. But when calculating the exact torque value, the torque value is measured with the part in the green circle. The following is a needle for irrigation. We recommend you irrigate after every drill using this needle tip. You can also use an 18 gauge tip. There are black markings on the tip. These black lines are spaced 10 millimeters apart, so during irrigation you can also check how deep it is drilled, including the gum height. When you irrigate, you usually spray it only on the outside like this in the third picture. Some people ask, the water comes out on the handpiece anyway, so why do you have to irrigate with a needle tip? We have studied the problem and we realized that bone heating happens at the bottom of the bone cavity. So no matter how hard the water is shot from the handpiece, it's hard for the bone to cool down at the bottom because there's no incision. So use the needle tip to cool down the bone particles and bone heating. Let's take a look at this video for the last time. This is a DIOnavi surgery video. You can see that the surgeon is using the bone flattening drill now. And now the drill tip goes in for irrigation. The 2x5 drill goes in and out, and the needle tip goes in again for irrigation. You can just think that irrigation is done after every drill. When irrigating, use a suction so that it is comfortable for the patient. Now this is the part where the fixture is placed. This is the bone profile drill. This leads some of the bone. The fixture goes in and the prosthesis is placed. You can see that the implant is placed in the same location as it was planned. That was it for today. Thank you for listening. This was Dio.